And at that point, when we didn't look at how many systems were we managing, and we saw that we had 800 systems that we were managing only for supporting the healthcare in the south of Sweden.
We were just talking about your role at Avenga, and maybe you can give a little fly into how you ended up here. And I know you've got a bit of a relationship with Capio, and that context I think is pretty important. So how'd you end up at Avenga, and where were you before?
No, when I was having my role at Capio as a technology innovation director, we were working with a lot of different companies or trying to do development, supporting our clinicians in different ways. So at that point, we worked quite a lot with Avenga. And after a while, it felt more natural to move over to the Avenga side. And so I moved over to the Avenga side and having a role of business consultant for the healthcare sector, both from the design idea point of view, and then it moves the full way over to being able to manage it and producing it. It could be nearshore, it could be developed, it could be product combinations, it could be partners in an ecosystem, and so on.
So what version of that with Capio at the moment? You seem, on the outside at least, you seem to be pretty integrated, like almost a sort of an arm within the company.
Yeah, I would say, I mean, we have pretty long tentacles going into going into the different ecosystems and EMR systems and so on the Capio side, and then also over to the Corti side, where we would have the AI models and the input regarding of how the system would navigate and would take the different decisions. And then we kind of have the system in the middle where we have the interface and the process and the flow of it. And the reason for keeping the process and the flow and the interface together is more or less being able to navigate between all of the different ecosystems and the different partners that are involved in the solution.
Yeah, and maybe more and more important for any of these systems to be effective, right? We've had a lot of sort of stopgap solutions and trying to address one problem at a time. And I think in the industry, at least like in health IT, a lot of those have failed when taken in isolation.
And I think also in my previously were IT director for Region of Skåne. And at that point, when we didn't look at how many systems were we managing, and we saw that we had 800 systems that we were managing only for supporting the healthcare in the south of Sweden.
Right. Yeah.
And at that point, you can understand that it's quite a lot of manual copy-paste that the clinicians do today.
Why does that happen? It still seems madness to me. How do you end up with 800?
I would say that it probably is a balance between an IT organization that were not able to meet the need from the clinician side, and a clinician side where doctors and professors and so on had opportunity coming from the research point of view, meaning that they were used to doing trials, set up tests, understand how things were working. So from their point of view, when it was possible to start to do things in a digital way, then they started to produce systems.
Okay.
So many of them are very, very small, and many of them are very, very focused on a certain kind of disease, medical area, process to support, and so on.
Do you think they need this many systems for those specialities? Is it serving a purpose, or does it need to be rethought?
I would say that it serves a purpose if you want to support something to 100%.
Sure.
But I mean, even if you look at an EMR system, or you look at an voice-to-text application or an AI, they don't support 100%. And they do shortcuts in the way how the data is stored or how things are set up. So I would say if you only would turn around that a little, twist it, the last 10%, and move it, you would be able to have a much, much less amount of system that to work with. And I think there is, I mean, one perspective is, of course, the maintenance and the cost for maintenance applications. But the other point of view is the working environment and the setup from a clinician point of view. And then when you go over to the view of doing digital service and you want to be able to support the patient in a the physical flow, then that's more or less impossible, because you can never integrate all of these systems. And that means that big chunk of the part that the patient would need to be able to follow their health or being able to navigate in a digital way is more or less not possible to do until you have consolidated the amount of system and have the data and the system in a different setups.
I've always had Sweden in mind as probably the nation leading in terms of digitalizing the electronic health records.
It's probably because Sweden were that early in the adoption of digital EMR systems that the amount of system has been dividing out and actually growing. I mean, if you would compare another country that were later on in the process of rolling out an EMR system, then they have been able to consolidate the system and securing that more and more of the data and the flows are actually connected to one system. I mean, I think we talked a little earlier about that. I were part of the Open HR conference last week, and it's really it's incredible to see how they can do with one version of the patient, one system that is patient-oriented in the way of how they can store the data and the working process. And then they have all of these different interfaces on top of it, but
right.
it's separately.
Excellent.
So they still have the data. They still have one point where they can do the digitization and the work of the data and the patient's flow and so on. And I think that's also where we will see the AI coming in, because with one source and one place where you would find all the data and one view of the correct data. Then when you start to work with an AI on top of that, then you know that it will not fetch any other kind of data.
You imagine that happening within hospitals or within municipalities or within nations or regions?
I think that it's the interesting thing is that it's happening in all of the places more or less right now. Going back to the European health data space.
Yes.
And the driver with the dates and commitments from that point of view, meaning that there is a governance pressure in many European countries of actually gaining the data and securing that we would be able to start to do that, even if I think it would take longer than what the EU expect. But
yeah, I want to know how long you think it'll take. We're both at Vitalis, the most recent Vitalis conference there. This EHDS, this European Health Data Space, was a huge topic.
Yeah.
The skepticism is that this is not something that's going to happen soon or smoothly.
If the focus regarding European health data would be solved by the different vendors and not solved by the hospital provider or the healthcare provider or the wellness provider or so, it would mean that they will not have one total version of the data. So I still think that there is a need for maturity going into what would be the best way of solving this problem and how do we aggregate data from a healthcare provider to a regional level, to a national level, to a EU level. Big part of the healthcare system today are based on handling emergency and a certain kind of disease. It's not about preventing you from getting sick.
It does seem like this fragmentation problem in healthcare is an old, stubborn, difficult, multifaceted, sort of all of the worst things kind of a problem to solve. And it is also relevant to how Avenga and Corti are working together.
Yeah. The problem is that when an AI service is summarizing it or consolidating the conversation and setup and they don't know the context of it, who decides what's important in the conversation? Is it important that when you talk to an elder person that they don't have a relationship with their children anymore? Or is it important to be able to navigate depending on in which context the conversation is happening? Do you need to have the information if they have been having heart problem before or not in the summary of the notes? And so what I feel that is interesting with the Corti setup and then the competence is the way that we actually put the knowledge about the context of working with the text. So it's not just a standard AI service. It's a service on which we have trained with the medical context around this kind of disciplines or this kind of questions. And that's where it starts to get really interesting.
Each stage in the workflow, the pre-authorization, the consultation itself, the documentation and summarization of what went on, and then finally taking that and translating that into these machine-readable codes for the sake of documentation, billing, statistics, and so forth. Trying to do any of them without the context of the rest of it is where these systems
start to break. Yes. I mean, from my point of view, the reason for why we are having codes in the first place, because we didn't have AI earlier that would be able to read a text and understand what's been happening from that text in more or less real time. So they need to have a very easy way of understanding what has happened. Oh, they had a diagnosis regarding diabetics, or they have been having a breaking leg and it has been happening in a ski slope, and so on. So the codes actually gives what have happened from a diagnosis point of view, and what's and then in putting into a context in which point of view it's been happening. But that you can put in a text now, and it can be read with an AI to do put in more contextual information regarding it. That was not possible before.
Information processing now is so much better. We no longer need to reduce information as much as we previously did. We can keep a lot more of the context. I mean, I don't know the coding space so well, but I know that in the United States, I think it's called ICD-10-CM, the sort of American equivalent of it. And it's huge, right? Like my colleagues say that, I think this is true as well, but my colleagues say that there's a code for being hit in the head by a turtle or something like that. There's like really precise codes, which, as you mentioned earlier, is probably due to the insurance incentives. So the business model there is like requires a lot of precision, you know, what's covered and not covered and all that sort of thing. But so they end up with a very, a massive, very complex, very detailed set of codes to try to cover all of that, which obviously AI can now support the processing of those codes, the creation of them, digestion of them, and so forth. And then, as we talked about, maybe we even get to a world where where it's not so necessary to have everything be so rigidly coded if the information processing doesn't require it. It's, as you say, we can get into population health and prevention and supporting the improved treatments in the life sciences, and if the data can feed everything.
No, when you are in these different dialogues with different healthcare providers or pharma companies or life science companies and startups and big companies and so on, and you start to have a dialogue regarding how they look at data or what's important for them. I mean, the amount of discussions that you can end up with today, it's just amazing, because the starting point from the conversation is so different. From a technical point of view, AI, I would say, is probably the area which is moving most rapidly. And then the coding and working with AI to do coding, and in which way would set up things, and which kind of software that are available and so on, is also changing pretty fast. Healthcare is not changing that fast today, but from a financial point of view and from a resource point of view and from an understanding of where would you be able to find resources and competence and humans that can do and produce the healthcare that are needed, then things are starting to move.
Have you had some projects that haven't been successful? Maybe we can talk about them as stepping stones towards the new approach, but where essentially it's just been, this hasn't worked, this has been a failure.
But yes, for example, we invested in doing what we call a clinical portal. We spent a huge amount of time on doing the integration with the EMR systems instead of focusing on the user perspective. Because the user perspective, we kind of thought that we need to have the technology in place first. And I mean, from my point of view, my learning is that there needs to be a balance. I mean, you can't only focus on the technology and try to solve that and then hope that the people still are with you at the end. So today, a lot of the other projects that we do, initiatives, it more or less starts with the people. It starts with the experience. It starts, what kind of change do we want to drive? How do we want to do that? And then you break it down from that point of view.
Thinking of the user perspective, you talked about 800 systems or something to manage in certain areas, and it's not always that extreme, but we know that doctors and healthcare professionals and maybe medical coders and anybody else like the healthcare professionals that are working with this system are dealing with multiple interfaces. They're often dealing with EHR systems that they might be new to, or that might even be new to the hospital, and they're not usually famously intuitive to navigate. I think they've gotten a lot better, but at least we've all heard the complaints. Can you talk a bit about essentially shielding the users from our experimentations and innovation?
But I think it goes back to, I think we talked about the 80-20% point of view. And if we can do one interface which would support 80% of the tasks that are done, that would mean a huge difference from an efficiency point of view. Even if it's like 800 system under, or if it's, I mean, as soon as a person needs to start to jump between different systems, interacting with different systems and the setup, then they start to add a risk from a patient point of view, but they also start to add it's consuming their time. They don't have the time to spend on it. So that would mean that information is not in all of the different systems. So from that point of view, I think that the idea of trying to add a shield or an interface on the top of it, that would be one interface that would support not 100%, because that's not reasonable, supporting the 80% of the task then, and making the day much easier. And then that would interact with APIs, RPAs, whatever it needs to interact with to be able to update the different systems and making sure that everything is structured and validated in a proper way. A few years ago, everyone was talking about an app that would be the interface. And then we talked about a responsive site or a web page or whatever to be able to have it on different devices. And then we are starting to talk over to possibility of, could it be an agent? Could it be something that would have a more or less a standard interface? You would chat to it, you would talk to it. You would start when we talk about the voice interface on having the dialogue, that you would not have typing any things any longer, and so on.
What's your opinion about where we'll end up in terms of the interface?
I mean, I think that from a standard interface, I would say that we are moving pretty rapidly over towards the conversational interface. I think that a conversational interface in form of an agent that would respond back to you and would handle things, and also would be able to actually executing things on your behalf. I think that that's kind of where we are ending up very soon.
Let's finally have a chat about the current project with Corti. And as I mentioned at the get-go, I'm not in the weeds of that project, so let me be the kind of naive person listening into where we're at. If you say anything negative, I'll obviously edit it out. But how long have we been working together, as strange as that question sounds? And maybe you can tell me where we're at today.
Yeah, I think we've been working like 3 years or something soon, going back from the first tests and in different projects. And I think that the project that is the main focus for right now, it's to be able to lower the burden on the administrational point of view. And that goes back to the focus in this certain case. It goes back to the certain for the private healthcare insurance that we can see is growing in Sweden and a lot of other European countries also. So there is a lot of different steps going through that process, from the point of view of finding the proper time to you as a patient, getting a validation that the insurance would cover it. And we need to understand what would be the recommendation coming out from the visit, going over to the point of view where we do the billing and insurance, and at the end, validating the patient's point of view, the result of it, and also sending the bill for insurance. Those different steps are things that we are including in the system for right now. And each of them, I mean, from a Corti point of view, Corti is involved in supporting the booking, validating that the visit is booked at the right kind of resource with the right kind of competence, depending on where the patient had described that they're having the problem. Going over to the part of the clinicians doing their documentation in the setup, and from that point of view, understanding is everything that is needed documented independently. If it's typed, if it's voice to text, a secretary doing it, it's an ambient scribe scenario or whatever. But we're just looking at the final result coming out from the documentation phase.
So just to be clear on that, so the focus is on the administration in and around the actual consultation, everything from, as you say, like booking the appointment through to processing it on the other end. Where does the technology, or specifically where does the AI support?
So the AI it's different models supporting different steps. So the first phase where the AI is coming in is validating the booking. So the AI is reading the information about the patient and reading the information about the resource that is booked for this meeting.
So it's been booked. The appointment has been booked, and now the AI is making sure that the right booking has taken place.
Because we have seen that from what the clinicians are spending their time on, or the healthcare provider, they're having problem with a patient being booked to the wrong kind of doctor, or to book to a doctor when they actually need a nurse or a physiotherapist or whatever. So what is done is the first point of view that to be able to take out that manual burden from the clinician's point of view, we are doing the validation. And if we see a problem with it, or if we are 100% sure, or the model is not 100% sure, then it raised the question to the interface and asking a secretary to look into it. Is this actually correct?
Interesting.
Or do you need to rebook it? For right now, it don't do the rebooking because it's only validating. But the possible next step would be that it actually would be able to provide the information to do a rebooking and saying, okay, I will recommend you to take this time slot instead, and then having a validation from the patient and the insurance company of doing it.
Excellent.
Then going over to the next step. The next step is that after the visit with the clinicians, if it's a bigger activity that needs to be done, then that needs to be validated or approved by the insurance company. So to be able to do that, we need to have the information around how many, what do we need to do? Do we need to do a replacement, or is it a surgery, or is it, could it be solved with the first visit, or whatever? That information needs to be in the documentation from the clinician. So we use the AI to read through the documentation and validate that we have enough of information, and it would make sense what we can see in the note comparing to the visit that has been booked with the information that we had from the beginning. And then we feed that information back. Not for right now, we don't do the calculation on a budget or an offer, but that's an next step. What we're aiming for being able to do. And then we get the validation on that. And then the booking process goes over again. So we book the doctor clinicians again based on what the AI has got approved on, what needed to be done. And then we go over to the next step. And that is that when the booking or the clinician have done the documentation of what they have done, then that needs to be invoiced. So then we read through the documentation again. We validate with which insurance company, meaning what would be the business deal with that insurance company and what would be possible items to bill for in this certain case. And the AI validates and says, okay, so in this case, with these possibilities, I would say that this is what you should invoice, and meaning how should it be coded in that way. And that the AI model also do with the Corti setup. So it's been trained on previously visits, previously agreements with the insurance company, what has been accepted, what has been billed since before. And with that as a base, it would suggest an invoice to send. And then the clinicians can frame that depending on if they feel that we're starting to get really, really correct. If they are comfortable with, okay, this kind of activities we are always correct on and this kind of thing, then they can squeeze what does it go forward doing automatically and what will not need to be validated by the clinicians or by the administration at the unit. Because, the aim is that we should be able to do most of it without a manual checkup at the end of it.
How much do you think, I want to ask you about the future, so you say the aim is to not need much of this manual intervention. Yeah. What do you think the future state is in 1 year? What do you think specifically your work with Capio, not the industry? Like, where do you think?
I really hope, and the business case is that within a year we would be able to have 90-95% of it without any interaction from a human in the flow. And that would also mean that we would be able to highlight the ones where we are not sure, because there's a two point of it. One is that we actually managed to point out what to invoice. The other point of view is that we actually can point out the ones which we are unsure, because if they don't know where we would have the ones that they should look into, because it could mean that they would do the wrong billing or miss point or bill too much and so on, then they will start to look at everyone. So we need to have both of the measurement in place.
And who do you think's, I think you've covered this a bit, but just to put a point on it, who will care? Who's going to benefit from all of this? So obviously there's a lower administration burden on some healthcare professionals. I'm not sure what the specific setup is at Capio, how much of that's done by doctors, nurses, medical secretaries and so forth, but there's an obvious burden reduction there. Will patients notice any of this change, do you think?
I would say that they would notice two things. One thing is that a patient today, when they getting booked to the wrong resource, if they are booked to a surgery that is good at hand and they have problem with their feet or foot instead.
What happens?
Then they will need to go home, because it's not the same kind of competence. They're not expert in of course they can do a certain kind of validation and understanding, but to actually get the result that they're aiming for, they need to have a new time. So we would take out those kind of problems from a patient point of view. Secondly, we would be able going forward to actually, with the help of AI, to validate and secure that everything that needs to be sorted out are sorted out, that the manual mistakes in the process is taking out, meaning that you need to wait extra time for your referral. There is not a budget, an approval on the financial point of view to have the booking in time and so on. All of that frustrational point from a patient point of view. And then at the end, I think that if we can take out that cost, we can actually start to produce more healthcare. And from that point of view, I think that the business case from a Capio point of view, it's all both from a cost point of view and from an efficiency point of view, meaning the volume that can, I mean, if we can take out a certain amount of time from the doctors, from the clinicians, from administration persons, that would mean that they can take in new patients.